Michael, people are often afraid when they hear the words palliative care. Can you tell me why this is so?
Yes, palliative care strikes fear into the hearts of most people simply because they associate it with death and dying. In other words, if they hear the words palliative care, they assume, if they are the patient themselves or if they're the relatives, they assume that death is near. And that was the case 20, 30 years ago when people were only linked into palliative care when in fact they were dying and death was just around the corner. But nowadays, palliative care has got nothing to do with how long they've got to live. Palliative care is more about the quality of their life, and people can be referred to palliative care because their illness is resulting in symptoms, whether they're physical or emotional, that are distressing and interfere with their quality of life. So that myth that palliative care equals death is far from the truth, and one of our jobs in palliative care is to try and impress upon people that referral to palliative care doesn't mean to say death is around the corner, but more that there is something that can be done to improve the symptoms related to whatever illness that is, so that they can make the most of whatever time they've got left, whether that's 1 day, 1 week, 1 month or 1 year.
Is this giving them hope?
Well, hope's, we all depend on hope for survival in the sense that, unless there's something to look forward to, life can be pretty dismal. Now, unfortunately, with people who have got a life-limiting or a life-threatening illness, often their hope is misplaced and their hope is for survival and the disease will be overcome. And referral to palliative care often just dashes that hope because they interpret the referral to mean treatment has failed and therefore I'm going to die. We don't mislead them and suggest that what we can do will actually prolong their life. What we offer them but are mini hopes. So if it's not the hope that they can survive their illness, the hope is that they can have a better quality of life so they can make the most of whatever is left. So obviously it's important to get people thinking about what's going on, and our aim in palliative care is not only to control the physical symptoms, whether it's pain, breathlessness, or in those with dementia it might be hallucinations or delusions, but it's also to help family, and if the patient is not demented, for the patient or the resident to come to terms with what's really going on and to set mini goals, and those goals may be to be symptom-free, it may be to live long enough that they can see out another anniversary, a wedding anniversary, or the arrival of a family friend or relative, something like that.
Often it's the family of a sick relative that opposes the introduction of palliative care. Are there any reasons for this?
Yes, the irony is that the family don't want the word palliative care mentioned, and certainly don't want the words death and dying mentioned, because they invoke so much fear and anxiety in them. They project that onto the resident or the person with the illness and think if they feel like that, the resident or the patient will feel the same. The irony is, from my point of view, and having worked for more than 20 years in palliative care, that all people who have got a life-limiting illness and who are referred to palliative care know deep down that they're dying. And part of the reason they won't talk about it is because they don't want to upset the family or friends who they intuitively know can't talk about it or don't want to talk about it. So the irony then is that family don't want palliative care mentioned, not because it'll upset the person with the illness, but because it brings up the whole topic of death and dying, illness and whatever that means. And they need to address it just as much as the person with the illness. So it's their fear and anxiety about talking openly and honestly about what's going on. And the more they can defer that, the more comfortable they are. And so when we introduce palliative care, or when I walk into, whether it's a nursing home or a patient's home, one of the first things I'll say, please don't say you're from palliative care. And the reason is because what it'll mean for them and future discussions with their loved one.
Can you tell me why doctors are sometimes reluctant to involve a palliative care approach, even though their patient is unwell?
Yeah, I think we could say there are several reasons for doctors' reluctance to call in palliative care, and the most common one, I believe, is because they still work with the old model, and that is palliative care is only introduced when all else has failed and the person is dying. In other words, they see it a bit like passing on the baton. The person is no longer eligible or will no longer respond to the conventional treatments, whether it's for their cancer or their dementia or their illness, whatever it may be. And so we've now reached a point where they're dying, and that's where palliative care comes in. So when a nurse or a relative talks about palliative care, if the GP says no, it's often because he believes palliative care is only called in when the patient or the person is actually dying, visibly dying. And that's often 1 or 2 days before they actually pass away. And from our experience, that's all too late, because if we're on about quality of life, openness and honesty in our discussions, well, there's no way that can happen in the last 2 days. So that would be the main reason. They're still operating in that old, archaic system which believes palliative care is just what you do when someone is close to death. The other reason may be because they themselves, if we talk about palliative care, they have to have these open, honest discussions with the patient or resident if they are still cognitively competent, and with family, and they may feel a dis-ease about talking about, the end of life issues. In fact, there has been a lot of work in America that has shown that the majority of doctors realise how important it is to talk about end of life issues, but they won't or don't because they don't have the skills, or they're afraid they'll make matters worse rather than better. And as a result, they'll try and avoid the situation, and that often means they just won't mention palliative care, or they won't introduce palliative care. And the third reason is because they equate palliative care not with dying, but with the use of morphine, and they themselves are afraid of the use of morphine, or don't know how to use it appropriately in the circumstances, and so will avoid the palliative care discussion simply because they don't want to get caught up with something they're totally unfamiliar with.
What are people most afraid of when they're dying, and how does palliative care deal with this?
It might come as a surprise, but death doesn't seem to be the biggest fear that people have when they're dying. So we're obviously talking about people who are not cognitively impaired, in other words, those that don't have dementia. But my intuition says that even those with dementia are aware of the fact they're dying. But they're not afraid of death itself. What they're afraid of is what they may have to go through before they die. So the fear most people have when they're confronting death is that they will either die of intense pain, or that they may suffocate, choke, starve, or they may die alone, in other words, without family being present. And that's often a big fear and a concern. It's not perhaps the physical symptoms, but the sense of isolation and doing death on their own. So one of my tasks, and one of the tasks of palliative care, and this is done by doctors or nurses, is to try and get people to talk about their fears. And a question that I commonly will bring up, and obviously you only bring it up when the situation is ripe and you bring it up with people who can understand the significance of the question, is of what you're asking, that is. And that question is, tell me, what are you most afraid of? And my experience is it won't be what's going to happen to me when I die, what awaits me after death. And it may be because I'm not a minister or a chaplain or a pastoral care person. They may ask those people those existential type questions, but the questions they ask doctors and nurses is, will I die in pain? Is there anything you can do to make sure I don't die in pain? Will I suffocate? And if they've got illness where they're short of breath, they'll be most afraid that they'll choke and be gasping for breath. So we spend a lot of time telling them about what we can do to prevent that, and we can virtually guarantee them these days that they won't die in pain, they won't die gasping for breath, they won't suffocate. And once they know that, there's a tremendous comfort and reassurance that goes with it. And that allows them to move on and deal with some of the, what I think, the bigger issues, and that is saying goodbye. And from another perspective, how we can preserve their dignity while they're dying too, which is something we take for granted but perhaps don't look at as deeply as we should.
So you were mentioning before about morphine. You say that morphine is a good drug, but isn't it addictive?
Well, there's two words that frighten most people, not only people who are dying or those with a life-threatening illness, but also family, and that is the D word, death. I suppose I should say three. The P word, palliative care, and the other one is the M word, morphine. Because when morphine is mentioned, like palliative care, there are a lot of myths and misconceptions that go with it. If you mention the word morphine, automatically it means to most people they're dying. In other words, if I've got to the stage that I require morphine, I must be very close to death. Absolutely wrong, that assumption. Morphine, if used appropriately and in the right doses for the right reasons, is a wonderful drug in relieving pain. Now, we don't, when someone has pain, we don't automatically jump into morphine. The people concerned, those with pain, may in fact respond to more simple pain relievers such as Panadol. But in the majority of cases, if they've got a life-threatening or a life-limiting illness, they do require a stronger form of pain relief beyond Panadol or similar drugs. And morphine is obviously one that we'll talk about. And so a lot of our time is spent dispelling many of the myths. And one of the myths is that if I'm on morphine, it's close to death, I'm close to death. And so I've already said that's not true. And we now know people can be on morphine for years because of not only of life-threatening illnesses, but because of chronic pain. And the morphine remains effective during all that time. They don't become addicted, and the reason they don't become addicted is simply because of the way we use morphine. Morphine or similar drugs, if it's used by mouth or applied as a patch to the skin, is absorbed so slowly it can't be addictive. And so the history of palliative care is that no one becomes addicted to morphine unless they were already addicted to similar drugs, and then there can be a problem. So it's not just reserved for when someone is dying, it's not addictive, it doesn't shorten life, which is another thing most people are concerned about. If we suggest morphine's going to be introduced, they think, well, not only is death near, but this is also going to bring death closer. But again, if morphine is used appropriately, it doesn't shorten life. All it does is improve the quality of life of that person, simply because it may effectively minimise their pain and hopefully eliminate it altogether. I should say this, in this day and age, there are many more choices other than morphine. And particularly for residents in nursing homes and particularly for people with dementia, we probably wouldn't use morphine when simpler drugs such as Panadol have failed. We would probably resort to the patches which are applied to the skin, and they are not only effective in relieving pain, but a much simpler means of administering pain relieving medication because they don't have to swallow it. The patch only has to be changed every 3 to 7 days, depending on the choice, and you can titrate the dose of the medication to their response. And I suppose the final benefit is it's not called morphine, they're called different names, and so when people hear about it, whether it's someone with their pain or their family, the fact it's not called morphine doesn't create any of the anxieties that I've talked about up to now.
So it's much more easily accepted by the families and...
Never any question about it, even though it's morphine in another name or another disguise.
What do you do for people in pain who refuse morphine?
Well, more often than not, it's the family, but it can be the person who's got the life-limiting illness. And then the question is not the aim of the exercise is not to try and convince them of the benefits of morphine and why they should go on it. The important message is to find out what their fear is. So in other words, to not challenge their reasons for not having it, but to ask them to talk about it. And quite often in the process of talking about it, we learn a lot about their fears and perhaps the agendas that underpin this wish not to go on morphine. Quite often we have to dispel some of the myths, but more importantly it's to allow them to talk, and if it is appropriate to dispel the myths. I would have to say that after 20 years there'd probably only be a handful of people who, after full and adequate discussion, have still insisted they not go on morphine, but they were quite happy to go on some of these other drugs because they weren't called morphine.
Does palliative care have a role in the care of those people with dementia?
Most certainly, and perhaps very importantly, simply because people with dementia have many issues that affect the quality of their life. And the difference between them and those that don't have dementia is that the people with dementia can't tell you about it. In other words, the frequency of pain, in other words, the number of people who have got dementia and pain that they can't talk about it is extremely high. Perhaps about 80% of people with dementia who are so cognitively impaired that they can't talk about it actually have pain. And quite often that pain is what's causing a lot of their behavioural and emotional problems. So palliative care has a very, very important role with people who have dementia, because their problems, not only their physical problems, are just as common and just as severe as in people who've got cancer, for example. It's much more challenging and much more difficult doing the appropriate or caring for them in the appropriate way, simply because they can't tell us and we don't have that feedback from them. But through trial and error we can often improve many of the symptoms that can affect the quality of their life. But the other important issue, and something I've not spoken about, is that palliative care is not just care of physical symptoms, not just the care of the body. Palliative care is holistic, and what we aim for in palliative care is firstly to make that person's body a comfortable enough place to live in. In other words, improve the quality of their life because they now don't have pain or they're not gasping for breath. But that's when the work just begins. It doesn't stop there, because then we hopefully can deal with the emotional and spiritual and existential issues. Now, obviously in dementia, we can't deal with that, but we still have to deal with those issues in their family and close friends, so we involve them. For those that don't have a cognitive impairment, such as people with cancer or heart disease or emphysema, controlling their breathlessness, controlling their pain is the preliminary step to dealing with their fears and anxieties. And that, in other words, that's when we get onto the real business. So I think it's important to realise that palliative care doesn't just look at the physical symptoms and what we can do to control them. We look at the whole person and deal not only with their physical problem and their disease, but also how this impacts on them at an emotional and spiritual level, and how it impacts on their family. Having said that perhaps dementia people are not able to talk about their emotions, my belief is we should still deal with this in the best way possible, and often we have to take cues from family and very close friends, and if they're in a nursing home environment, from the staff who have been particularly associated with their care because they know much more about them and their responses. And not to deal with emotional and spiritual issues in dementia people simply because they don't have cognitive impairment, I believe is a cop-out. And we should find ways and means of trying to deal with this through photos, in other words, things they can recognise. Because my belief is when someone is dying, they actually go through a return journey. In other words, they retrace their life, and my experience is that they will talk about their life, and they're often retracing their life. Now, people with dementia can do that by looking at pictures, hearing the type of music that are familiar and which they can resonate with. There was a wonderful ritual that a family did for someone that was dying. Now, this man didn't have dementia, but if he did, this ritual would have been just as effective with him with dementia as it was when he didn't have it. And that was, he was a train driver. So what the family did, recorded steam whistles and just played that by his bedside when he was dying and when he was unconscious, because that was a way of him reflecting on his life while he was unconscious. And what we know to be fact is that people who are unconscious are very aware, and so it's important to continue that return journey while they're in this unconscious state. And the evidence suggests that people with dementia are similarly aware when they're unconscious, and because their means of communication is by emotions and behaviour, that when they're unconscious, anything that makes an emotional connection with them can have a profound effect. So I suppose all in all, I'm trying to say that the palliation of people with dementia is very, very important, very challenging, and something that needs to be dealt with in slightly different ways compared to those that don't have dementia.
To round off, I noticed at your presentations at residential aged care facilities, the question of when to begin palliative care was often raised. Could you talk about this issue, please?
Well, palliative care, if we're talking about aged care facilities, really commences the day they're admitted or to that unit. And hopefully it's commenced well before that, but let's just focus on the residential aged care facility. I like to think of palliative care over 5 stages rather than just palliative care, meaning the same type of treatment right from admission to the time they die. But if we look at it over these 5 stages, it becomes, I think, easier to introduce. In other words, it's less confronting when people are talking to families, and it makes the palliative care makes more sense when we look at it in stages. And the first stage is thinking about the illness and how that person would like to be cared for and treated once they're in that aged care facility. What that comes down to is an advanced care directive. In other words, if they're able to participate in the discussion about how they would like to be cared for from here on in, then they should participate in that, and they complete an advanced care plan stating not only how they want to be treated but where they want to be treated. Now, if we've got someone with dementia, obviously the family and next of kin would, if an advanced care directive hasn't already been formulated, that they would actually get involved in those discussions and complete that plan. So really, the first stage is just looking at the current situation and the future about how we would like to deliver care. The second stage is looking at quality of life, how we can improve this person's quality of life so they can enjoy whatever time they've got left, hopefully free of pain and distress from other symptoms. So we're looking at essentially symptom control. Have they got pain, and if so, what's the best way of treating it? If we do need to initiate some medications, does the resident, does the family have some misconceptions about the drugs we may want to use? And if so, we need to talk about it and dispel those myths and if they are then happy with that discussion, we go ahead and introduce those treatments. But remembering palliative care is not just about care of the body, it's about care of the mind and the spirit. So we not only look after the physical symptoms, we give the family and the resident the opportunity to talk about some of their fears and anxieties. And I stress that because there is a belief in some parts of the world, and certainly in the healthcare profession, that palliative care is simply about making someone physically comfortable, and once we've done that, the job is done. From my point of view, the job just starts once we have them physically comfortable. Because death invokes a lot of fears, and if we don't deal with those, we're not really comforting the person during their final days, weeks, months, or whatever. So the second stage of the model is symptom control, but remembering that holistic dimension to it. As they start to deteriorate, those first two stages virtually take place the time they come in, and they still may be fairly functional, fairly active, and if they do have dementia, still able to get around and involve in some of the and become involved in some of the activities. But as they start to deteriorate, they become less agile, start to lose weight, don't eat as well, in fact often refuse food, then we need to start looking at what medications really do these people need. And do they still need to have their antihypertensive drugs? Do they still need their cholesterol lowering drugs? Do they still need their sugar lowering drugs? In other words, medications they may have been on years before and which at that time were useful, but now are not only useless, but become a burden because they are swallowing these pills which are not having any beneficial effect. I've often found it's harder for doctors to stop treatment than to initiate it. So sometimes we need to do a little bit of arm twisting to get that happening. But we're doing this really because those treatments don't benefit people at that stage of life and become a burden, particularly when swallowing is difficult. So I think that's a very important third stage, but one that's very hard to get people to initiate simply because it's almost a recognition that this person is getting much closer to dying. The fourth stage is the end-of-life care. In other words, these people are now almost bedbound. If they're not bedbound, they're chair-bound. They're not eating very much at all. They've lost a lot of weight. And this is when you've really got to think about the best way we can care for these people. From a physical, or the physical dimension, in other words, symptom control, we must remember at this point, they don't absorb medications terribly well. If they're on a patch for pain relief, because they're often wasted and bony, the patches don't adhere well, and so the absorption through transdermal patches is not as good as it should be. And you may find that as they're deteriorating, they become more restless, or behaviourally they may become more agitated. And that's not just because they're dying, it's because they've got pain, and that pain has surfaced because they're not absorbing the drug as well. So it's always important to bear in mind that when they're losing weight, particularly if their medication is transdermal, they're probably not absorbing it as well, and you need to review the most appropriate pain relieving management at that stage. And I won't go into details on that because it becomes a bit prescriptive, but generically we say when they've lost weight, they're probably not absorbing medication transdermally as well. But that also applies to oral medications. And so that's another reason to look at those unnecessary drugs, because not only are they now pointless, but they're probably not being absorbed, so why give them? But it also applies to some medications that are useful, in other words, for symptom control. And we should look at whether they are absorbed. Well, it's hard to look at whether they're absorbing them. What we can only assess their response by their behaviour, and if they seem to be settling, then we can infer that the medication is being absorbed. But if they're not settling and we think it's because of pain, that's when you start to look at whether medication needs to be given under the skin, subcutaneous injections, which are essentially painless, but we can be fairly sure those medications are being absorbed. So that's the end of life stage, stage 4, planning for comfort and making sure as best we can that they're getting the optimum symptom control. But the other dimension with that is looking at foods and fluids. They often don't want to eat. And that is not a problem for the resident who doesn't want to eat. It's not a problem for a dementia or Alzheimer patient who doesn't want to eat. It's a problem for the family, because they equate not eating with starvation, and if you starve long enough you die. And if that's the sequence, then you can reverse it in their mind by feeding them. In other words, if you feed them, they won't starve, they will put on weight, they won't die. And that's a myth, because these people are not eating and they're not eating, they're losing weight, but their weight loss is not because they're starving to death. Their weight loss is because their illness, whether it's cancer, heart disease, emphysema, dementia, is because the metabolism in their body has changed and they can't effectively use the medication. And it's like their body has recognised this. In other words, the body's natural intelligence is saying food no longer is working, food no longer is helping. They turn off and they don't eat, they lose weight, but it's not starvation. It's called cachexia, and cachexia is an illness in itself almost, and basically with cachexia the body can't utilise food. And so our job then is to tell families that what is happening, so they understand the person is not starving to death, they're dying, not from the lack of food, they're dying because of that illness which has led to this cachectic state. And there's no way you can reverse that with food or whatever, drips, feeding through a tube, feeding through what we call a peg tube. That doesn't work. That food, whichever way it goes in, is not going to be absorbed, won't result in weight going up, won't prolong life. In fact, the evidence now suggests very strongly artificial feeding, particularly through peg tubes or force feeding, not that we would ever think of doing that, but if it was done, doesn't prolong life. More often it shortens life because it leads to regurgitation and people inhale that food. So it's getting families to understand that this is the natural process of dying and there's no way we can reverse that. Any attempt at reversing it is not only doomed to failure, but can lead to consequences which may in fact make whatever time is left more burdensome for the person that's dying, simply because it can cause nausea, result in vomiting, and worse still, a pneumonia because they're aspirating their food. So families, I find, generally can understand that, but they have great difficulty with the fact that their loved one is not drinking because they know what it's like not to drink. They get excessively thirsty, and they've come from a model of care when someone can no longer drink, they automatically get a drip. In other words, they've been in hospital, generally, or if they haven't been in hospital, they know when someone goes to hospital and can't drink, a drip will go in. So when the resident in a nursing home can no longer drink, the family become concerned about the possibility of dehydration and they will die of thirst. And the question which is implicit, or they may ask, why aren't you giving them fluids through the vein? The truth is, fluids can't be utilised when someone is close to death, just as foods can't be utilised. And what will happen, any fluids that you give them, either by forcing it, which as I said we wouldn't do, but through a drip into a vein or under the skin, just seeps out into the tissues and is not utilised. Not only that, but the fluids we give that way doesn't relieve the only significant problem associated with not drinking, and that is thirst. The only thing that will improve thirst in people who can no longer drink and who are dying is to keep their mouth moist. And so we can encourage them to do that by, if the family still, if the person concerned, whether they've got dementia or not, can still sip fluids, encourage them to sip fluids. If they can't do that, to just encourage them to do what we call mouth care. In other words, moisten a swab and just to moisten their tongue and their lips with that swab. That to me is so important, not only because it relieves the thirst that's associated with not drinking, but it gets the family involved in caring for their loved one. In other words, they no longer feel helpless, and it's that helplessness around death which causes family members a lot of angst. And if they can become involved in delivering care, in this case the simple task of moistening a swab and then running that moist swab around the mouth, they're not only helping with the thirst of that person that's dying, but they're actively participating in the care of the person they love. And that has enormous benefits for them at that immediate moment, but also in their subsequent grief. And it's been found that the more relatives can participate in delivering care, the less complicated, protracted and severe their grief will be. So that's stage 4, which is the end-of-life care, withdrawing drugs, giving the most appropriate drugs to make sure they're comfortable, dealing with the issues of food and fluids. And hopefully, having done that and progressing through that model of palliative care, the person will die not only free of pain, but will die a dignified death, which is what we all hope for. And the family have become an active part in the care, and so when we get to stage 5, which is the bereavement stage, in other words, we're now dealing with the care of family, that grief, we would hope, has been appeased somewhat because family have understood right from the word go what we've been doing. Palliative care has been introduced to make this person's life more comfortable, give them better quality of life while they're alive, and when they're dying, to give them a peaceful, comfortable death, hopefully free of suffering and certainly with dignity. And the experience is people's memory of the last hour of someone's life is the principal factor that influences their grief. So no matter what's happened in the previous months or years, if those last hours have been done as well as possible and the family have been involved, that's what determines the grief that they will experience. Sure, there's going to be a lot of sadness and grief and some suffering that goes with it, but that's normal. They will have a normal grieving process simply because they've understood, they've been informed, the misconceptions have been dealt with, they've been empowered, they've participated in care, and they can reflect back on that and said, not only did mum, dad, or whoever die hopefully pain-free and with dignity, but we contributed to that. That is our gift to the person we've loved, and hopefully that goes a long way in helping them deal with their grief. And that bereavement phase is the final phase of the palliative care model, and you can see how that depends very much on how well the previous 4 stages have been done.
Thank you very much, Michael.